Well, good morning, everybody. My name is David Rubin. I'm from the University of Chicago, and joining me is my very good friend, Miguel Reguero, the newly minted chair of gastroenterology and hepatology at the Cleveland Clinic. Miguel, congratulations on your new job.
Thank you, David.
We want to start by thanking you all for joining us for a very early breakfast before our busy DDW gets started today. And we're both excited to talk about this topic because it's timely for many reasons. Stopping ulcerative colitis progression in its tract, in part because we have new options available to us in managing ulcerative colitis and new data to consider and new strategies to incorporate. So as you already heard, this is a highly interactive program. At your desk or at your tables are your iPads that will enable you to be interacting with us as we go along. And we encourage you to ask questions, which we'll try to incorporate as we do this. We built that into our program this morning. And of course, to get your credit, many different types of credit, follow along in the instructions there, and you can fully get not only CME, but a variety of other mock and other things that will help you with your additional credit. I want to start by acknowledging that this morning's program is due to an unrestricted educational grant from Takeda Pharmaceuticals, and we're grateful to them, and of course to our friends at CME Outfitters who put together this entire program. Now, I also want to acknowledge and welcome all the people who are around the country in the United States who are live streaming, watching us as we do this. So this program is actually being broadcast, and people at home are watching or somewhere else. You may be wondering why you didn't just roll out of bed in your hotel room and do the same thing, but we're glad that you're here because you get the breakfast, and we're happy to have you all with us. So for those who are logging in from at home, we're welcoming you as well, and you can ask questions as we go along, and we look forward to that. So with that, let's see. I want to remind us what we're going to try to do over the next hour and 10 minutes or so. We're going to examine the rationale for early effective treatment for altering the progressive course of ulcerative colitis. We often talk about Crohn's disease being a progressive disease, but we've come to appreciate very much in many different ways that ulcerative colitis is also progressive. So the evolving and emerging principle and available therapies to treat ulcerative colitis and prevent progression are important to understand. Secondly, we're going to utilize the AGA ulcerative colitis care pathway that was relatively recently published to help guide personalized biologic therapy to halt disease progression. It's a different thought about how to incorporate treatment options in managing ulcerative colitis when you think about using this particular care pathway, and Miguel and I will discuss that with you. And then thirdly, we'll talk about some of the evolving disease monitoring strategies, the newer ways to think about how to measure the disease over time and how to make sure that we're achieving our goals of controlling the disease and, of course, improving patients' quality of life. So with that, I'm actually going to hand it over to Miguel and let him take us away on learning objective number 1.
Great. Well, thank you, David. So the first learning objective is to examine the rationale for the use of early effective treatment in altering the progression of ulcerative colitis. I think many of you have seen this slide before in the classification of ulcerative colitis severity, and you probably can't see the small print at the bottom, but Truelove and Witt back in 1955 came up with a classification for disease severity, which has been updated over the years in different guidelines and journals. And really, this is at the core looking at symptoms, so stool frequency, but also other signs of toxicity, bleeding, and some other objective parameters. I would dare say in the office, when you see a patient, you use this in a subtle way, maybe not classifying with a score, mild, moderate, severe, and who needs to be hospitalized or considered for surgery. We'll get into this in a minute, but I think the evolution now is more towards risk factors that predict colectomy and need for early biologic use.
So this is actually a video, and what this is supposed to show is that there's a paired infographic from this morning's program, which we hope you'll all go to at different times. And the infographic is available to you and has these interactive components. This is just a sped up video of one of the things that the infographic shows. In this particular case, you're seeing the automatic video here demonstrating the histologic features of what colitis looks like. Of course, traditionally we've accepted that active colitis has a certain degree of inflammation, and the chronicity is demonstrated by the architectural changes and the crypt architectural distortion that can be seen. As some in the room may know, we've recently demonstrated that with newer therapies, we've actually been able to show that the histologic changes of typical ulcerative colitis have actually disappeared. And we have demonstrated that up to 10% of patients who've been in stable remission for a long time actually normalize their mucosa. And it's of great interest because clearly that's a deeper level of control than we've known before, and there's interest now in whether or not that might result in us modifying treatment paradigms once patients achieve that deep level of histologic remission. But just so you understand, the infographic that accompanies this program and that will be available on the websites for at least a year after this program is concluded this morning enables you to interact and really learn about a lot of these features.
So with that in mind, and considering the aspects of disease progression, histology, structural damage, I had the honor a few years ago of participating in this AGA clinical pathway for ulcerative colitis. And you may have seen this before, but it's fairly practical in its use. If you consider the patient who would be high risk for needing colectomy, and many of you could say, well, I see them in the office and I know what they look like, but sometimes it's not as clear, and I would argue that these are also the patients that we would consider early biologic use. So age under 40, younger age, more extensive disease, very high C-reactive protein, steroid use, and probably the number one feature, and if the take-home message would resonate in terms of who we should treat earlier with more aggressive therapy, would be deep ulcerations. Deep ulcerations predict colectomy. Deep ulcerations predict a more severe course. And then obviously if they have infections, C. diff or CMV, maybe in some of the Q&A we can discuss that. That's also a factor that leads to more progressive disease. And then obviously those who have a history of hospitalization.
And one of the pearls last year that came out of DDW was that study, I think it was from the Mayo Clinic, that saw that patients who had C. diff also could have CMV simultaneously. So just a reminder to everyone that when you are investigating a patient who's newly diagnosed or certainly relapsing while on immune modifying or immune suppressive therapies, you should always be looking not just for C. diff but also for CMV. And if you find one, don't forget that you should still be looking for the other, and having both obviously has a worse prognosis.
And then if we consider, aside from the pathway, what about disease progression? So many times we see patients who have proctitis or left-sided ulcerative colitis, and we wonder, is this a patient who could progress over time? So this is actually an interesting Swiss study that looked at disease extent over a median duration of 9 years. And you can see from left to right proctitis to left colitis to extensive colitis, and what happened over a period of time. And the bottom line number to remember, and when patients ask if they have limited disease, what's my chance of progressing? It's about 15%. 15 to 20% will progress over time and have more extensive disease.
One of the clues about that is that patients who have been stable and now relapsing, you should always consider whether that's happened. It's amazing to me that we still don't know why people have extension or what determines extent of disease.
Well, and David, some of the work you've done, and I think this is why we're often asked, should we biopsy normal-looking right-sided colon? And David's done work on histology, as he's mentioned, but patients who have histologic activity on the right side of the colon may not also have a higher risk of colon cancer long-term, but those may actually be the patients who would be more extensive. So what are some hard endpoints in terms of outcomes? And these seem kind of simple, but one is colectomy. So patients who progress with their ulcerative colitis to requiring colectomy. And you can see this Ipsen study, which looked at the rates of colectomy in ulcerative colitis in the first 10 years of diagnosis. And it's about 10%. Now, we've seen patients, especially now younger patients, come in with fulminant colitis, failing treatment, newly diagnosed, going to colectomy early. So we are seeing something that's different, but the rates are about 10% in the first 10 years. Hospitalization is another endpoint by which we look at disease progression. And you can see here that about 50% of patients with ulcerative colitis require a hospitalization at some point in their disease course. I would submit if you have a patient early that needs steroids or you admit to the hospital, that's the patient that's more likely to require colectomy. And I think that's the patient that we have the opportunity to start a biologic or a more aggressive treatment strategy early.
I think that's one of the main points and things that has changed in the way we manage ulcerative colitis and Crohn's disease for that matter, but is the incorporation of prognosis in treatment decision. I think we've been doing this backwards for a long time. We've waited for people to be sicker before we actually give them the treatments that we think they may need. So Miguel, in your practice, if you make a new diagnosis of colitis and they have deep ulcerations, they're in the hospital from the start when they're being diagnosed, how do you incorporate that in your early treatment decisions and in your subsequent follow-up?
Right, so we'll get in, so the more fulminant patient who's early admitted, especially if they have a low albumin, they're sick, one thing I would say is I think in my practice, the days of old of waiting 5 to 7 days in the hospital on IV steroids is essentially gone. And I think you and I practice very similarly in that by you rule out C. diff, rule out CMV, try to find anything that's reversible. But within the first day or two, if they're not having a rapid response to corticosteroids, we're moving to either cyclosporin, which you can talk maybe a little bit more about, or in the hospital, it's still probably using more infliximab because of the weight-based dosing or experience with more severe extensive colitis. I think we'll see emerging data potentially in vedolizumab and some of the other agents. But those are early factors and features by which we shouldn't wait and treat early. We also know that ulcerative colitis has a risk of colon cancer. I think the national cohort studies from years ago, which reported a high rate of colon cancer, is probably lower than we had thought, but it's still higher than the population. And especially, and the point I'd like to make is the smoldering patient that you have with ulcerative colitis that you follow over the years, and each time you do a colonoscopy, they have smoldering active inflammation. Those are the patients in my practice that I've seen progress to dysplasia and cancer, and I think mucosal healing is paramount in terms of this. And this is just a study, again, showing that there are subgroups that have higher risk of cancer, PSC, ulcerative colitis that's not in remission.
So the work that's been done by the St. Mark's Hospital in London, which many here know a bit about, has demonstrated that it's cumulative inflammation over time. They actually developed essentially an arithmetic scoring system that the amount of inflammation on every colonoscopy adds up to an increased risk. And that's important because the implication of that scoring system, once it's validated, and there's others working on this, would be that if you can control the disease early, you'll ameliorate that risk. And it's a very important. Miguel, we're getting some questions, a couple from people at home, as well as I think a few from in here. So let me just stop us for a second and ask you a question. Yep. Somebody said, but if they have deeper ulcers, would you use steroids longer in the hospital setting?
So that's an excellent question. The answer is no. Actually, if they have deep ulcers, I wouldn't use steroids longer. If anything, I would move to a biologic or a more aggressive strategy earlier. So for those that are comfortable with cyclosporin, I think that's reasonable. I personally, in these cases in the hospital, they're very sick. We'll start infliximab, and I've been tending to do 10 milligram per kilogram. We'll do a rapid sequence, meaning if after 3 to 5 days they're not improving, we will give a second dose. And if they're not improving at that point, these are the patients that require colectomy. But waiting longer on steroids, I don't necessarily do. I will give them 2 days, but I won't do that longer. And David, I don't know what you do.
No, our practices are very similar. I think 3 days at the most while we're monitoring CRP, waiting for the CMV and biopsy results to come back. Everything's going at the same time. We even have a protocol now when we admit people with severe UC, we get a consultation from our surgical colleagues. If they're sitting in the hospital that sick, even if it's a new diagnosis, we want our surgeons to know, not only as a professional courtesy, but sometimes these patients do go south on us quickly. And also, frankly, we want patients to be aware that there's a lot going on here and they should know they're being monitored by all of our teams.
And if they haven't had it, I tell the trainees when they hit the door, send off the hepatitis B. Quantiferon Gold is usually what we'll get in the hospital as well.
Great. Lots of questions about biomarkers and treatments. Just so you know, I'm not ignoring all of you. We're going to get to some of that, and I will definitely come back to them. And somebody watching at home said Miguel has a nice tie.
Thank you. Thank you for noticing. All right, so moving right along. So ulcerative colitis, we talk about this progressive disease. I think, I'm not going to take a poll of the room, but if I were to ask many of you, do you think Crohn's is worse or less severe than ulcerative colitis? I think there's a sense that Crohn's disease is a worse disease. However, I think this point is made that ulcerative colitis is progressive. It can have structural damage. And it's interesting, when you look at this study in 1966, way back when, the mention of pseudopolyps and obviously cancer, but you see the word stricture. And stricture, actually, if you look at the fibrosis that occurs in the wall of patients with ulcerative colitis, you've all scoped them, and you see these rigid colons that are non-compliant. So this isn't just a mucosally based disease, and this does have impact on motility, anorectal function, impaired permeability. So I don't think the days of ulcerative colitis is milder and easier to treat. We really need to get out of that pattern of thinking.
Remember that in those days, 1960s, it was all barium enemas, right? So the way they described the morphologic changes of the colon was how they looked at risk. Now, of course, we have the additional endoscopic images.
And what were the treatments then? Steroids and sulfasalazine. So we've come a long way. So I think this is an interesting study looking at long-term outcomes as far as remission. And just to ground you as far as the slide, the orange box is clinical and endoscopic remission, what we would consider potentially deep remission at month 3, although there's no histology. So deep remission. The blue box is clinical but not endoscopic, and then yellow is no clinical or endoscopic remission. And probably intuitive, but if you look across the parameters on the bottom, colectomy, immunosuppression, relapse, hospitalization, those that have this deeper remission do better. Those that are not in remission, either clinically or endoscopically, have very high rates. So again, the point being, treat early, treat hard, put them in remission, and avoid some of these long-term consequences.
So just, Miguel, if I could ask you, do you think that this is unique to steroids, or is it the general response to early therapy that predicts what's happening?
Right, so that's a good question. I should have pointed that out. This is a study that looks at response to steroids at 3 months, so those that had an early response. The way I look at ulcerative colitis, and David, I think it's more early therapy, but I put ulcerative colitis into 2 buckets. Those that respond to steroids and probably then mesalamine, that's about half, and those that do not. And I think the ones that do not are the ones that you don't see 3 months later doing well. Those are the ones you're progressing beyond mesalamine and steroids, not sticking them on steroids long term. So I think it's early response to treatment.
I like this study because they incorporated the endoscopic remission as well as the clinical response, and that really is where the field has gone, and that's really what you should be thinking about as the clinicians managing these folks.
Oh, and somebody said, Dr. Rubin, you have a great tie as well.
Kiss ass. Okay, so let's move on and talk about one of the important topics here, which is if the patient's feeling well, why bother looking? And of course, we've come to appreciate that symptoms don't often correlate with endoscopic findings, but this is not new. So there's this wonderful study from 1956 from the British Medical Journal by a then young Sidney Truelove. In fact, at that point, he was an assistant physician. Miguel already showed you the Truelove and Witts criteria that grew out of this incredibly important ulcerative colitis program there. And what they did here is they characterized the clinical state, endoscopic, and the pathologic state of these patients with ulcerative colitis. And I just want to highlight for you that in the first 3 bars there, the patient's clinical state is described, and those patients who are in clinical remission, feeling well, you can appreciate that despite that, there were still those patients who had mild to moderate histologic findings, so active inflammation, and even a few who had severe inflammation despite being in clinical remission. Just like we know is true now, I just wanted to tell you this is not a new concept. It's been appreciated from the earliest days of rigid sigmoidoscopes. And even those patients who had endoscopically normal appearing mucosa, at least the way it was defined then with the limited technologies of those early sigmoidoscopic equipment, you can appreciate that some of them still had mild to moderate histologic activity. The point here is that patients' symptoms are not sufficient to determine whether they're in remission, and likewise, when patients have symptoms, it's not always due to the inflammation that we know is there or that we
And David,
find.
a couple questions came over about histology, and I mentioned this, but with this in mind, do you biopsy in somebody with left-sided ulcerative colitis and a normal appearing right colon, do you biopsy normal mucosa, and if so, why?
I do biopsy the normal appearing mucosa even in follow-up surveillance exams, but I'll tell you that the data supporting that practice don't really exist. I biopsy to know whether the patient has had, unbeknownst to us, progression of their disease at some point that isn't active at this time. I also biopsy to document the extent of the disease and clarify other features, even though I might have known that from a prior exam. Doesn't mean I do the extensive biopsies every 10 centimeters like we used to do for surveillance, but rather to characterize the presence of the disease there. And that's really because I want to understand a bit more about how to stratify the risk for dysplasia and cancer. The reason I said the data aren't that good is because the data for extent of disease as an independent risk factor for cancer and colitis were all from barium enemas. They were not from histology. But all the recent studies that looked at dysplasia risks, whether it's in Chicago or throughout the wonderful programs in Europe and in the UK, all were using biopsies to determine extent of disease.
But I think in your practices, if we can't sit up here today and say you must biopsy normal appearing colon. However, I think we're emerging toward that, and if they do have histologic activity, I would take that as a factor for more aggressive disease, even if it looks normal.
Yes, I completely agree, and for stratifying them in terms of when their next exam might be for surveillance. If they're active when you scope them, the St. Mark's group would suggest you bring them back sooner. Somebody here is asking, do you biopsy again if in 2 years if the right side was okay? That's not necessarily always the case, but you want to make sure you know what you're dealing with and obviously think carefully about this. Now, we have looked at a variety of different studies, and there's a nice meta-analysis that demonstrates consistently that despite what is defined as mucosal healing, and endoscopically and in clinical trials, that doesn't mean a perfect mucosa. Mucosal healing is defined often in these older studies as a normal appearing mucosa, which is a Mayo subscore of 0, or even a Mayo subscore of 1, which includes erythema and mild inflammation. That technically, according to regulatory bodies and what led to a lot of the studies, was considered healing. So in a meta-analysis of 13 studies, it was found that patients often had symptoms despite what was called a healed bowel. Now, even when the bowel looks normal, you've heard from Miguel already why some patients might still have symptoms. A chronic ulcerative colitis, even when it's been treated, can result in patients having more irritable bowel or overlapping bowel or dysfunctional bowel problems. And that's another reason why using objective markers to assess the disease is really important, so that we know that we're not over-treating or under-treating our patients. And in many of the clinical trials, and here is the example from the Act 1 and Act 2 trials for infliximab in non-hospitalized ulcerative colitis, you can see that nearly twice as many patients had mucosal healing as defined in the trial as achieved clinical remission. And that disparity has been brought up many times. Why? How can that be? You'd expect that it would be the other way around, but now hopefully you have some insight into that. You also have to recognize in the older trials, the way the endoscopic mucosa scoring was determined was by the local investigator, and we've now learned there's lots of bias that can be introduced when that happens. So what do we know about measuring and understanding outcomes related to mucosal healing? Well, we know a few things. The first one is we know that you have to look for it, and you have to know that you want to achieve it. We've also learned that when you achieve mucosal healing, regardless of what treatment you use to get there, the outcomes are better both short-term and long-term. And what we're talking about in those outcomes includes such things as, of course, the patients achieving clinical remission, but their quality of life, avoiding relapse, avoiding recurrent steroid exposures, hospitalizations, and surgeries. We have to learn a little bit more about which therapies can actually get us there, and it's become an important secondary endpoint of most of our clinical trials and certainly all of our available therapies. And then we have to also understand, when do you look? If you look too soon or you assess too soon for mucosal healing, you might be underestimating the true impact the treatments you're using will be having. And if you look too late, you're going to drag things out longer than necessary, and the patient's going to be suffering or having progression of their disease. So how is it defined in ulcerative colitis? Well, a return of a normal vascular pattern has been defined as part of this, so I always comment on the way the vascular pattern looks. You can also have the vascular pattern become, actually look more hypervascular due to prior inflammation. Of course, you want the absence of friability or ulcerations, and you'd like the mucosa to look normal or near normal, which can be defined as slight hyperemia or a slight granularity, and it's all in the eye of the beholder, unfortunately. It's a challenge. Now, when it comes to histology, you should know that the FDA has become interested in histology as an endpoint for therapeutic efficacy, but the data are not yet robust enough for us to endorse that. The question often comes up in clinical practice, should you be treating to histologic remission? And we aren't quite there yet, but I'll tell you in my own practice, if somebody has histologically active disease, even if it looks okay, I'm going to be concerned that they're going to have a relapse, and I'll definitely be discussing potential management options and adjustments. Now, lastly, I wanted to just briefly summarize what I think is a nice way to grade the endoscopic severity. This is called the Ulcerative Colitis Endoscopic Index of Severity, or UCEIS. And the bottom line here is it only has three main parameters, and they're the ones I just mentioned to you. The vascular pattern, whether or not there's bleeding, and the presence or absence of erosions and ulcers. Those three things. So in your endoscopic reporting, when you do your exams of your patients, keep in mind those three different parameters. Either describe them verbally, or if you learn how to use this scoring system, I think it could be very useful for you. Depending on which endoscopic program you're using in your unit, many of them now have drop-down menus that let you do this. In our unit, I've actually had these printed out and they're posted on the wall above our computers so that both I and my colleagues and our fellows can learn to use these and start using them more routinely. The next issue really is fecal calprotectin. Could I actually ask those who are in the room here, how many have used fecal calprotectin in your patients with ulcerative colitis? I know Miguel and I have. The interesting point about fecal calprotectin, let me remind some of you that this is a protein that's from the cytoplasm of neutrophils. And the general principle is that calpro is extruded into the lumen of the bowel when people have inflammation lining their intestine. Originally in the United States, it was FDA approved for the distinction between infection and inflammation versus an irritable or non-inflammatory or infectious cause of diarrhea. So one of the pearls for you who are using it in your practice or those who would like to start using it is that when you order a fecal calpro to assess your patients with IBD, even if it's part of a monitoring schedule, I suggest that you make sure that the code for diarrhea is part of the request when you submit those. Now, it's been used for diagnostic purposes, but where we've really started to embrace it as well in IBD has been in assessing disease activity as well as in response to treatment. Highly sensitive, short half-life. When somebody receives an effective therapy, a calprotectin will drop precipitously and can be a very reliable marker that they're starting to respond. At this meeting, one of my colleagues is presenting work that shows that you can even use a fecal calpro to predict who's steroid dependent. In other words, if they still have a high calpro despite feeling well while they're on steroids, if you start tapering the steroids, the high calpro gives it away. It tells you that they're going to have a problem as soon as they drop below 20 or 15 milligrams of their prednisone. Now, also calpro has been shown in some studies to be prognostic, meaning that if you have a high calpro and the patient's feeling well, they're likely to relapse in the short term, and they may have problems. And of course, we use calpro now in many of our research protocols as well. This is just another quick view just to remind you of this wonderful infographic that's been developed and will be narrated that will be accompanying this program. It enables you to learn a little bit more about what the different potential endoscopic appearances of colitis are, mild, moderate, severe. We'll talk about the different scoring systems. This is all available for you in the infographic. So again, encourage you to go back to that. Now, next is just the general principle that the severity of endoscopic disease correlates with colectomy. Miguel already told you this. This is regardless of what treatment the patients may receive. We recognize that deep ulceration is a very important marker. You saw the Truelove and Witts criteria for severity of colitis. What you may not have noticed is that the old Truelove and Witts criteria and even the modified version of it that was used in the previous ACG guidelines did not include endoscopic severity. It's hard to believe that, but that's because back then they didn't have this as well. Now, I'll tell you that the newer ACG ulcerative colitis guidelines that'll be released this year have specifically added that as a category as part of how we assess, and the AGA care pathway you're learning more about today definitely includes this. So in your mind, you need to remember, it's not just how they look clinically to you, it's also how the mucosa looks.
Actually, maybe we can pause on that slide or this slide as well, but so there are a number of questions as I look at this that are coming in terms of mucosal healing, histologic healing, and then how to treat inpatients, and there were a flurry of those. So maybe we can pause on this for a minute. So David, you mentioned a minute ago histology, and I think I wanted to clarify a point that you made in some of the questions. At this point, if the mucosa appears normal and there's histologic activity, are you pushing therapy more to heal the histology?
Within limits. So what I mean by that is I will make sure that the therapy they're already on, they're taking. I will consider adjusting the dose of their existing therapy, but I don't think the data are robust enough for me to jump to a different class than somebody who's feeling well and their endoscopy looks okay.
And I think the same applies. There are a couple of questions that people had. How hard should we push mucosal healing? And I would look the same way. If you have somebody with very severe deep ulcerations and you put them on combination therapy, for example, and they heal the mucosa, but you still see some mild inflammation, I do exactly what David does. I optimize therapy. I will check drug levels at that point and optimize even further if we can. The other series of questions where there are a lot of questions about inpatient treatment for ulcerative colitis, and just to pause on that for a minute, some of them were over how do you get inpatient therapy approved and insurance to pay for it. So fortunately, and depends on your hospital now, Remicade based on contracting has been accepted by most inpatient formularies. That's taken a while. I'm not saying that's true everywhere, and I'm sure there are many of you that are still fighting that battle. The other question people had was if Remicade fails, and I should say, if infliximab fails, do you go to vedolizumab or cyclosporin? And I'll hear what David has to say in a minute, but if it's a sick inpatient failing infliximab after 2 doses, I'm more likely to go to colectomy than another treatment, especially cyclosporin or vedolizumab. But David, what do you think about that? And you've used cyclosporin quite a bit.
Right. Well, the question becomes why are they failing the treatment? And when patients have low albumin and severe colitis, of course, one of the reasons we fear that they're not responding to a monoclonal antibody like infliximab is because they're leaking protein. And you just can't get enough drug to do what we need it to do. And we've had examples where in the case where we're trying to load somebody with infliximab or even using accelerated dosing, which has been the description from some of our colleagues where they give 10 milligrams off the bat in the hospital setting and then another dose 3 days later. The truth of the matter is when people have a low albumin associated with severe colitis, I think that they're essentially just wasting those proteins, whether it's because they have such a severe inflammatory burden that they're sinking all the antibody or because they're literally leaking and pooping it into the toilet. So I've become a fan. Of course, I mentioned already that we get surgical consultation right away, but of using a monoclonal antibody-based treatment to try and induce remission in those settings. And in the right patients, not everybody, using cyclosporin or sometimes tacrolimus to induce remission or at least get them out of the woods and then maintaining them subsequently, usually as an outpatient after they've responded with vedolizumab has been an effective strategy. Why Vito? Because combining Vito with tacrolimus or cyclosporin was a safe option, and that's actually in press right now in CGH, and at this meeting, one of our colleagues is presenting a prospective trial of exactly that strategy. So it has to do with understanding why is the patient not responding to the therapy when you're considering your other options. I will tell you, however, that surgery is still an appropriate consideration there. I have not used vedolizumab inpatient, and I don't think I would chase a primary non-responder to infliximab who's in the hospital setting with Vito, and I don't know if there's data to support
And
it otherwise.
just since you brought up vedolizumab in the hospital, and again, I would do the same thing. It's a very sick inpatient. I'm not starting Vito. However, I think it's because we have a lack of data rather than it potentially is not effective. We do know in the outpatient setting, if Vito is your first medicine used for ulcerative colitis, the response is very high, whereas if Vito is used as a second or third line, it's not as well, it doesn't work as well. So earlier use of Vito has shown excellent results, and it may be that at some point we'll start using it in the inpatients, but I think for now we're using infliximab or cyclosporin. So great discussion, David, go ahead.
That's okay. I see there's also a bunch of questions about calprotectin, so let me just try to address one or two of them. One was really what's the threshold, or what are the numbers that we think about? So the statistical analyses of calpro have generally shown that if the calprotectin is under 250, that's associated with clinical remission. There's a really nice smaller study from Hong Kong from our friend Su Ing that showed that if it's under 100, it's associated not only with clinical remission but endoscopic healing. And if it was normal, which is usually under 50, it was associated even with histologic healing. And that's in ulcerative colitis. One of the other questions from the audience was, is it more reliable in UC than Crohn's? And the answer is yes. Although it can be useful in Crohn's, I agree with that point that someone made. Okay, moving on. We know that regardless of what treatment you use, if you heal the bowel, patients are much less likely to end up having surgery. That should be obvious to you at this point. But this very nice population-based study demonstrated that it didn't matter what therapy the patient received, it was whether or not the bowel was healed. So if we focus on that, we can appreciate that. All right, Miguel, let's talk a little bit about how to use the AGA care pathway.
So again, coming back to the idea of what's our goal is deep remission, what are the clinical parameters? We know it's mucosal healing, and the outcome is obviously to prevent surgery, cancer, hospitalization. And one thing that we can't lose sight of, especially as we work more with the payers, is this idea of disability, loss of work, loss of school, and I think that that's an important outcome that we can't lose track of. So you've all seen this treat to target idea, certainly with Crohn's disease. It had emanated initially from rheumatoid arthritis, but I think with ulcerative colitis, we should look at the severity of disease and take into account patient-reported outcomes. So PRO, you're going to hear a lot about this. You've already heard about it. The FDA now uses this in terms of measuring success clinically for treatment. And the patient-reported outcomes for ulcerative colitis are what you see in your patients, bleeding and bowel movements, diarrhea. So those are the two patient-reported outcomes with ulcerative colitis. We obviously want to maintain a steroid-free remission. I think we've seen this time and time again. You've heard this over the past decade. And then ultimately, can we change the natural history of IBD? The same themes repeat itself, but the last line there is, can we reduce cost? So I've been involved in these IBD medical home models in Pittsburgh, now taking them to Cleveland. And it's interesting to work with the payers around some of these initiatives and looking at cost parameters, not necessarily cost avoiding biologics. That's not the message. If anything, in our medical home, we use more biologic therapy. It's actually reducing unplanned care in terms of hospitalization, ER, loss of work, loss of school. Those are important outcomes as well.
I just want to add that the one symptom that keeps falling off, but we've tried to include in our new guidelines, is urgency.
Yeah.
Certainly urgency, or even having incontinence. Those are such disabling, terrible components of UC, and they never quite make it to the discussion of clinical remission. So we tried to incorporate that in these new guidelines that are going to be coming out.
And although not in the guidelines, I think what a symptom patients equally are bothered by is this tenesmus. So this dry heave of the rectum, if you will, these patients who have that bothered symptom related to rectal changes. So why don't we achieve preferred outcomes in everybody? This is a recurrent theme, and I can't stress this enough as we see patients not only in referral centers, but you see these in your practices all the time. The patient who's had disease for a long time and comes to see you is less likely to respond than somebody who has disease, say, less than 2 years. So waiting longer is a better prognostic way of assuring that they're going to need surgery. Not to say people don't respond, but if we wait too long, it's too late. Therapies that don't work. We're learning more about this precision and personalized medicine approach. So there may just be, from a molecular level, that certain medicines don't work in certain patients. David already mentioned, and I do the same thing, if you have a patient on treatment and they start to lose response, well, first of all, make sure it's not something obvious like C. diff, but then make sure you've optimized that treatment, whether it's therapeutic drug monitoring or other ways as well. And then treating the wrong problem. Is this irritable bowel? Is this an infection? And then symptom improvement's not enough. Again, the theme of you can place a patient on steroids. Many patients hate steroids to begin with because of the side effects, but often you control the symptoms with steroids. So the pathway, I'm not going to continue to beat a dead horse, if you will. You've seen this already. I will point to the last line. There is a clinical decision support tool. If you go to the AGA, you can actually download this on your phone. The pathway comes up. It's very easy to use. It just takes you through low versus high risk. And this is really just a screenshot of that. On the left-hand side, you see low-risk patient in the middle. And this is, again, are the patients that probably respond to a course of steroids and mesalamine. On the right-hand side, though, are the high-risk patients. And these are the patients that we want to treat early, avoid hospitalization, avoid colectomy, and again, get them on the best treatment as early as we can. So when do we start biologics? We already talked about things like deep ulcerations, extensive disease. Those are, I think, are no-brainers, if you will. But if you have a patient not responding to steroids or dependent on steroids, or if we use immunomodulators, which we didn't talk about much here, my personal opinion, there are probably still about 20 to 25% of patients who respond to thiopurine, methotrexate, and ulcerative colitis. We don't have as much data. I think in the era where we're worried about safety and side effects, and thiopurines probably do carry a higher side effect profile than the biologics, especially than vedolizumab, and we have alternatives. I think we're all collectively using immunomodulators less as monotherapy, but more in combination with anti-TNF for immunogenicity. And then finally, clinical predictors of a poor outcome at diagnosis, we've already talked about. So these are the currently FDA, and I can now see all of them are FDA approved with tofacitinib coming out just a few days ago. So the 3 anti-TNFs, vedolizumab, tofacitinib, you can see the mechanism of action in the middle. The studies, if you want to look up the actual studies based on their names, are there as well. But I think one of the important aspects that come up are the risk-benefit, and I think we can't lose sight of the adverse events that are related to these medications. So the anti-TNFs, they've been around for a long time. I think we're comfortable knowing that we need to screen for TB and hepatitis B. The problems we see with the anti-TNFs are basically infection-related and opportunistic infection. If you skip down to the bottom with tofacitinib, probably many of you haven't used it or used it off-label in some limited experience. This will be an oral form, and this will be, I think, probably patients wanting this treatment because it's easy as a pill. But I would say a word of caution. This will have side effects. It does have a strong immunosuppressive effect. Herpes zoster is something we'll need to look out for. It does raise the lipid level, which is interesting, and although we haven't seen cardiovascular side effects related to this lipid increase, I think this is something we need to look at. And then vedolizumab, in terms of safety, when I at ECHO put together a safety pyramid, vedolizumab is what we would consider the safest biologic we have at this point. Aside from some mild nasopharyngitis, which when my patients get this initially, it goes away. It's not, I tell them, it's not an infection. It just might have to do with the mucosal lining in the nasopharynx, and somehow they're actually getting some symptoms. It's almost like a mild hay fever, and that usually goes away. But incredibly safe medicine with vedolizumab.
So go back. Lots of questions came in. Let me just try to ask you a couple comments. One was somebody wanted to know demyelination risk with the anti-TNFs. Is that something you routinely talk to patients about? Have you seen it in your practice, and should we have listed that there?
So I think there are a lot of side effects that we did not list that get in the order of very rare. I would put demyelinization in that category. It is something I have seen. I've had a couple cases of optic neuritis related to anti-TNF. Fortunately, those patients, that was reversible, but then I would not move to another anti-TNF agent. I do tell patients when I counsel them, I go through generally and tell them if they have any types of symptoms that may be out of the ordinary, visual changes, any paresthesias, things that they may not get. But I generally don't use the word demyelinization because they don't understand that, but I've seen that rarely.
What about somebody who has a family history of multiple sclerosis?
So multiple sclerosis, if the patient has it, it's easy. I don't use anti-TNF. If it's a family history, I will say that now with other options, and certainly for ulcerative colitis in the outpatient setting, if we were to get into positioning therapy, I am using Vito more as first line for my outpatients with ulcerative colitis. The safety and efficacy profile is good in bio-naive patients. However, just to be fair, if it's a patient that you want to put on an anti-TNF and they have a family history of multiple sclerosis, I will still use anti-TNFs in that case.
And I'll answer. There's a couple questions here about malignancy risk. So in the many hundreds of thousands of patients studied, there has not been a solid tumor risk with the anti-TNFs. There is a small signal for melanoma that has come up, but that hasn't been replicated in every study that's looked at it. The lymphoma risk with anti-TNFs is either quite small or negligible when you incorporate the understanding that thiopurines drove most of that risk in the early studies and exposures. Haven't seen those risks with Vito and TOFA yet, but obviously we want to keep an eye on the emerging therapies and long-term follow-up, especially with tofacitinib. Now, the other question that's come up here, Miguel, has to do with inpatient use of either Vito or tofacitinib. We talked briefly about Vito. What about using the small molecule that just got approved in the inpatient setting? Is there a rationale for that, and are there any data?
So there are no, I have not personally used it. I'll start by saying I've not used tofacitinib for inpatient UC at this point. Are there data? Not that I'm aware of, although you may know of some. And is there rationale for it? Well, the only potential rationale, and David mentioned a minute ago, if we're using immunoglobulin-based treatments that are lost in the stool, so all of our monoclonal antibodies, there's potential that tofacitinib will overcome that rapid clearance, but we have absolutely no data on that. And I'm not sure that that would be something I would do at this point without more investigation.
Yeah, I'm not aware of data yet, and I would just add that this is a potent immunosuppressant, so don't confuse the convenience of it being oral with the fact that it has that impact. So I'm sure people are interested in it. We are interested in using it and thinking more about whether this would be an option for our patients when we're worried about those protein loss scenarios. Okay.
Great. So this is the effectiveness of biologics on mucosal healing. And again, you can see the kind of the blue diamond on the bottom where you see the letter number 1, that's the line of unity. So anything that doesn't touch 1 favors biologic on the right compared to left. So all of them heal the mucosa. I will point out that Vito, lizumab, and infliximab seem to have a higher mucosal healing rate than the other anti-TNFs listed on this slide. The real-world effectiveness with vedolizumab, we now have longer-term safety data that looks very good. We're also seeing data in terms of response and remission across studies, and pooled analyses have shown that vedolizumab is an effective treatment and that adverse events and safety events are still very low. So this is something that still has a very good safety profile. Tofacitinib, this is the Octave 1 and 2 studies on the left, the induction studies, and the sustained remission study, longer term 52 weeks on the right. Blue is tofa compared to placebo, and again, you can just see here that there's a statistical benefit for tofacitinib in both induction and in maintenance of remission.
So for our U.S. colleagues here, the FDA approved this therapy just last week on Wednesday, and the dosing schedule was 10 milligrams twice daily for 8 weeks for induction, which is what the ACTAV 1 and 2 trials were designed and demonstrated. For maintenance, it offered an option of 5 milligrams BID or 10 milligrams BID. And there was just the additional caveat in the label that if the patient hasn't had significant response by 16 weeks, they shouldn't continue the therapy.
And as David mentioned, the language approval is for moderate to severely active ulcerative colitis.
Well, back to the infographic, we're just obviously trying to tell you more about this because it's such a valuable teaching tool. But this actually is part of that infographic, and it goes through the mechanisms of these different therapies, or at least the putative
Infographic on
mechanisms.
speed.
Yeah, you probably wouldn't do it quite this fast. But that's how the infographic can be used to understand more of these mechanisms. I would say that the mechanisms are important, but what we really need to be doing in our field is getting to a place where we're making smarter decisions and have therapeutic biomarkers to guide us in choice of therapies. Okay, and then the last point is to talk a little bit about how we can incorporate all this into practice. How do we choose therapies in UC? We've had a flurry of questions from the folks here, and I think some who are watching from their offices or from home, about which treatments to choose in whom. And the reality is that there are 4 major factors that play into this, or maybe 5. The first, of course, is the sickness of the patient and their prognosis. The second is the effectiveness of the treatment you're choosing. The third is the safety and the relative safety in that individual patient. Fourth has to do with convenience, whether it's oral, injectable, or infusion-based therapies. And lastly has to do with whether or not you can get it. And that, of course, has become a reality of all of our worlds, wherever you are and wherever your practice is. So it becomes complex in this regard, and I think that when we need to demonstrate patients are responding to their therapies and we need to think about moving through these different options, there's, of course, what you're most comfortable with, what you've been using, what you know about, what your team knows about. But I think that you should be exploring your horizons a bit more and thinking carefully about safety, understanding the available data, working towards targets of better treatment control and objective measures of disease control. And the general strategy that has emerged, in addition to a care pathway, and this is something that you should be leaving this meeting really thinking about your practice, and what I say is systematizing it into your practice, meaning every patient you put on therapy should be going down a pathway where you understand what your goal is with that individual patient, what's the specific target that might be of great importance. It could be as simple as clinical remission initially, but what objective measure you're going to use to assess whether the therapy is getting you where you need to go. Followed by assessment of that target at a defined and predefined time interval. So you put your patient on their new therapy, when are you going to reassess? In general, we say between 3 and 6 months after you start therapy, with the understanding that the patient shouldn't be getting worse while you're waiting, right? And then what are you going to do when you assess the target if they haven't achieved it? Knowing what your next step is and having explained that to the patient. So it's no longer a quick discussion where we say we're going to put you on this treatment and you'll let us know how you're feeling. It's about, we're going to use this treatment, we're going to reassess your disease, and if that's not getting us where we need to go, we're going to increase the dose or we're going to change to this treatment. Now, I'll add that the other conversation we have in the US especially is if your insurance company will let us, unfortunately. But it's a reality, and that's part of the discussion. Now, the other thing about using a treat-to-target strategy that can help us in that regard is it defines how long we're going to wait as we move along. So if we are forced, despite our best efforts, to use what's called step therapy, where we have to put patients on treatments we may not want initially, let's define the interval where we're going to move on from that therapy if it doesn't get us where we need to go or if the patient is not tolerating it. Now, you might want to know what the targets should be. Well, this paper, which is a little bit dated now from 2015, represented the opinion of an international group of IBD experts. And focusing just on ulcerative colitis because of our morning symposium, the STRIDE consensus paper suggested that in UC, your target should be a combination of the patient feeling well, which is resolution of rectal bleeding and their altered bowel habits, and I would throw in there that we want urgency to be gone, with some endoscopic improvement or endoscopic remission. Those two goals, a composite endpoint, should be your target. Now, the nice thing is that since 2015, the use of CRP and especially calpro has become more accepted. And I would suggest to you that after your initial endoscopic evaluation, using calprotectin as a serial way to monitor as you move through the different treatments is a completely reasonable thing to consider. So if you're bewildered and wondering, how am I going to know which treatments I should be using in my different patients, I hope that what Miguel and I have discussed this morning has given you some suggestions. We're going to flesh that out now by answering some of your questions. But even when you're not 100% sure, taking a treat-to-target strategy, especially in your higher-risk patients, can certainly help you move along and also help you with the conversation that you must have with your patients when you're making these decisions. So with that, Miguel, I'm going to actually put up some of the goals that we'd like people to have from this discussion, but we have a whole bunch of questions from the room and from people at home, and perhaps we can go through some of those.
Right. So maybe I'll take the first couple, and then David, there's a question about systemic effect of vedolizumab on extraintestinal manifestations. But before we get to that, there are a number of questions on safety of pregnancy, and I'll extend that also to breastfeeding. So Uma Mahadevan, as you probably know, and at this meeting is presenting quite a bit on the PIANO registry, which is a long-term safety in pregnancy with different exposure to medications. And the bottom line is this: so the anti-TNFs and vedolizumab are safe in pregnancy. I personally continue them in pregnancy. I would not stop them. I'd be curious to hear what David said. I used to really try to hold the last dose about 4 to 8 weeks from delivery. I'll be honest and tell you transparently, I've not done that as much anymore, and I just treat through because I get worried that we get off cycle and the mom then flares. The one thing that the child will receive, a rotavirus, which is a live vaccine at 2 months, and I tell the mom that who's exposed to any immunosuppression during pregnancy that that's the vaccine that, since it's live, probably should not be given at 2 months. In terms of breastfeeding, I actually had the pleasure of reviewing this, and it's now accepted and will come out. The breastfeeding, it's safe, is the bottom line. There's minimal minimal passage of these biologic agents in breast milk to the baby. And in terms of looking at safety as defined as infections, and developmental attainment and goals, there was no alteration to 1 year. So the sample size is low. Yes, we need more data, but the bottom line is anti-TNFs and Vito are safe in pregnancy, safe in breastfeeding. We shouldn't recommend stopping these. Tofacitinib, we don't have enough data yet, and I think most of us are a little bit cautious in tofa in pregnancy. So in my personal practice, when I start to use tofa, this is something, at least until we have more data, I would hold for 3 months before trying to conceive. That's based on no data that I know of, certainly in IBD. But I don't know if you want to add to that, David, and then vedolizumab for extraintestinal manifestations.
Well, at the University of Chicago, my colleagues and I do many things differently, but when it comes to treating our pregnant patients, we are the same, which is that we treat through with the anti-TNF and with Vito throughout pregnancy, and we reassure our patients that that's considered safe and it will keep their disease under control. Agree completely that as of now, I would not have women planning pregnancy on tofacitinib until we know a little bit more about that therapy. So that one I would completely agree with your comment and caution there until we learn a little bit more.
And one thing, sorry, about tofa is that it's also a very fast half-life. It probably clears within a matter of 7 to 12 hours, assuming that there's a normal creatinine clearance. So this is renally excreted, so it clears from the body very quickly. So that's
okay.
Just another point.
There's a related question from the audience about combination therapy, and I think we could talk about that right now, and as it may even apply to pregnancy. So Miguel, do you use combination immunomodulator with your anti-TNF biological therapies, and do you use it in combination with vedolizumab when you're treating patients with ulcerative colitis?
Yeah, so those are excellent questions. In general, for a new start, or I should say, for any anti-TNF therapy, I will, in the right setting, which I'll come to in a second, use combination with thiopurine or methotrexate. And the reason for that is to decrease the immunogenicity. There probably also is some pharmacokinetic benefit in terms of the anti-TNF. The exceptions are patients over the age of, and now that I'm in my lower 50s, I keep bumping up the age, but patients over the age of 60, those that might have concomitant infections, I'm worried about infections in general, I will use monotherapy anti-TNF, and then I'll be more aggressive at proactive therapeutic drug monitoring to make sure I hit the right levels.
Why not use Vito?
So for vedolizumab, in terms of monotherapy, and then certainly in the patients who have these potential risk factors, and I mentioned a minute ago, vedolizumab has become my first-line biologic for outpatient ulcerative colitis, and I use that as monotherapy. I do not use that as combination therapy. I think when we add thiopurines to vedolizumab, we've essentially negated the safety benefit. The only time I'll use combination with vedolizumab as a thiopurine or methotrexate is if it's a patient who's previously already been on one, certainly 2 or 3 anti-TNFs. If they've developed antibodies to those TNFs, I will tell the patient, we're treating you more aggressively, the safety benefit may be lost, but that is then the time that I would use combination.
And what about the patient who's on combination therapy with a thiopurine and pregnancy?
So at this point, if they're on a combination therapy, generally at 1 to 2 years after being on combination therapy, I'm de-escalating off the thiopurine. So if it's a woman who's on combination, that means she has very aggressive disease and I'm treating her as such, and we can define that as multiple extensive disease, perianal fistula, whatever it may be. And I will continue combination in pregnancy in that setting of remembering that the reason she's on that combination is because her disease is very severe.
I agree with everything you said, and just to repeat a couple things, for the most part I'm using vedolizumab as a monotherapy except in a patient who's already proven that they tend to be immunogenic. So if they had antibodies previously to an anti-TNF and I move to Vito, I will use a combination approach at least until I have better evidence on how to do that differently. Otherwise, we looked at our use of combination therapy with vedolizumab, and in general, even when it was used as a first-line therapy, we didn't get an efficacy bump by being on a second therapy at the same time, and you, at least in theory, reduce your safety benefit by being on a different treatment with it. The question that Miguel hinted at for me was an important one, which is how do you approach the patient who has ulcerative colitis with extraintestinal manifestations? And this is important. We have to remember that we're not just treating the bowel. These patients often have systemic inflammatory problems. And it, number one, depends on the type of extraintestinal manifestation. If the patient has the most common one, which is a disease-related arthralgia, I will treat using the therapy that's going to fix their colon, and usually their joints will improve. If they have an arthritis or they have bad pyoderma, I will not use vedolizumab. I'm going to prefer to use anti-TNF. And for that matter, I've even used ustekinumab, which has had some nice data early for pyoderma, and we think will be working well in colitis eventually. So that's important. Sometimes the question comes up about whether the use of vedolizumab as a gut-selective therapy is uncovering other immune conditions or other inflammatory problems. And I think that that's a real phenomenon that we should know about. I think it's not common, but it does happen. I'll tell you that looking at the Gemini 2 study with vedolizumab, which admittedly was for Crohn's, the number of patients who developed new arthritis or arthralgias on Vito was not different than the number who got it on placebo. So at least with the most robust data set in a post hoc analysis, we couldn't show that. Having said that, there's always the anecdote of a patient who has a problem, and that has certainly happened in our practice as well. So these are the types of things to keep in mind.
Sorry.
That's okay.
I just thought of something as you were talking with Vito. So, David, does vedolizumab work for central axial arthritis, PSC, and when would you not use Vito? If you're saying that Vito sounds like, from what you're saying, and I agree, if it's a peripheral arthropathy, which is the most common type of extraintestinal manifestation, vedolizumab does work for that because it heals the bowel. How about the central arthritis, uveitis, pyoderma?
I still use anti-TNF there, and what we should be thinking about as well is whether TOFA may have a role in those patients in the future. But for the most part, I'll choose anti-TNF. Anti-TNF is an excellent therapy for the spondyloarthropathies, and I think that we should keep that in mind. It's very important, and certainly for uveitis as well. We have a case that we presented at ACG last year of a patient who had an inflammatory arthritis with a resistant colitis that we treated with tofacitinib, and she did excellent. So I think that is a new option for us to be considering in these scenarios as well.
So we have a lot of vedolizumab questions, and I just wanted to clarify one first. So vedolizumab, I do continue and use in pregnancy and breastfeeding. I do not stop. So vedolizumab safety in pregnancy looks very good. In terms of dose intensification of vedolizumab, and I'll tell you my thoughts on this, and maybe David, you can give me yours as well. So for patients who receive the 0 to 6 week dosing, they're on every 8-week dosing, and whether you track drug levels and they're low, or you go to every 4-week dosing, is there any benefit in going beyond every 4-week dosing? So either going higher dose or more frequent dosing. In my practice, if they're on every 4-week dosing and they have a good drug level, then I will switch to something else. And that's true of the anti-TNFs. I practice the same way. There are patients that I have had on Vito for some time whose levels are low on every 4 weeks, and I've actually reloaded them with 0, 2, and 6, and then go back to every 4. But that's different than the patient with good drug levels of Vito on every 4. I just switch at that point.
My approach is a little different, which is surprising because we're usually very similar in what we do. When patients are losing response to therapy, are they infected? Prove that they're really inflamed and it's not an irritable bowel or something else, and then assess where the drug may be. So all that makes sense. But with vedolizumab, there's some very intriguing work that suggests that even at regular dosing, there's nearly 100% saturation of the alpha-4 beta-7 lymphocyte targets. So we clearly don't quite understand the idea of why more drug might work. And therefore, I'm not the biggest fan of using the drug level to guide how to change the dosing. Instead, what I've done and what was presented by a different group last year at DDW, although I haven't seen it published yet, was that in a patient who's responded to Vito and lost response, I give them monthly dosing for 3 doses. And if I recapture them in those 3 doses in those 3 months, I will continue at that dosing schedule and just be glad it worked and not really know why, and I'm not looking at levels there. If they don't respond within 3 months, I move on to something else. I don't have any data, nor do I have any experience in going any higher than that.
And I agree with that. There is a question about PSC and vedolizumab.
Right.
So I think initially there was some hope because it is taken up by the biliary tree that vedolizumab would work for primary sclerosing cholangitis. At least to date, those data have not borne out. So the data for Vito used to treat effectively, heal, or improve PSC has not been found. It also conversely has not made PSC worse. So if a patient has PSC, there's no reason not to use Vito, but I don't think we can say that Vito works for PSC.
Right, so my comments about PSC agree completely. There's a nice study that a variety of centers did together demonstrating that the liver enzymes, if that's a marker at all of PSC, did not improve on vedolizumab. And the second point I would say is that while it's interesting, maybe we're just treating PSC too late, just like when Crohn's has progressed to fibrosis. Maybe we're not capturing it early enough. So that's still a challenging disease process for us to manage. And I think we should just keep that in mind. Nonetheless, remember that when you're treating patients with PSC, they can have more inflammation in the proximal colon that you may not know is there. That's why patients with PSC and colitis don't always have very obvious symptoms. And so more recently, we've recognized the importance of using objective measures to know what's going on in the whole colon, whether that's a colonoscopy, which you're doing anyway for surveillance, or certainly using calpro and trying to treat them to heal. That it seems to be a very important point about PSC, so keep that in mind as a take-home message today. So with that, we're getting urged to move along here. I want to remind you that there are some great downloadable resources associated with this morning's program. The slides are available to you. Miguel and I are available to you, although not right now because we're both running to the next session. And we'd be delighted to interact with you and hear more about some of your feedback. Please do fill out your evaluations so that we can learn from this program if you like the format, if you liked the interaction, and certainly take the time when you have a moment to play with the infographic and share it with your colleagues. With that, I want to thank CME Outfitters, I want to thank Takeda, and I certainly want to thank all of you for getting up so early this morning and joining us.
Thank you.